Imagine having an aggressive autoimmune condition that leaves your skin looking like crushed white tissue paper.
Right.
Like a condition that fundamentally changes the architecture of your cells.
Yeah, it's intense.
But, and here is the crazy part, despite looking incredibly severe, it doesn't hurt. It doesn't itch. You might, never even know it's there unless someone actually points it out to you.
Exactly. It's a massive biological contradiction.
So today, for you, the learner, we're looking at a total medical rule breaker, a skin condition that acts completely differently just depending on its geographic location on your body.
Yeah, we are talking about the exact same disease process, the same hyperactive immune cells, but the zip code entirely changes the patient's experience.
And I know, medical terminology can be intimidating. You see a white patch, you Google a few symptoms, and suddenly you're drowning in Latin phrases, right?
Oh, absolutely. Terrifying statistics about tissue damage.
Exactly. But that is our mission today. We're going to translate the jargon and explore the mechanics of what's actually happening under the surface.
We have a really fantastic stack of sources today, too.
We do. We're looking at clinical guidelines from the British Association of Dermatologists, along with patient leaflets from the NHS, the Primary Care Dermatology Society, and some specialized women's health clinics.
Yeah, and we're pulling it all together to demystify this highly specific presentation called extragenital lichen sclerosus.
Yeah, let's unpack this.
So, assuming our listeners are already somewhat familiar with the baseline typical lichen sclerosus, or LS.
Right, the typical one.
Yeah, which is a chronic inflammatory autoimmune condition that primarily affects the genitals. But we need to pivot almost immediately to the anomaly today.
Because genital LS is notorious, right?
Oh, very much so.
Yeah.
It causes intense, unremitting itching, structural scarring, severe pain. But the extragenital part of our focus today, it just changes all the rules.
Well, before we jump into the geography of it, looking at our sources, the demographics for this seem a bit wider than I would have guessed for a localized autoimmune issue.
How do you mean?
Like, the typical narrative you hear is that this is strictly a postmenopausal women's disease. Is that actually the case?
Well, not quite. The demographic data has shifted quite a bit as diagnostics have improved.
Okay.
Yes, it is heavily skewed. It affects at least 1 in 100 people assigned female at birth, making it 6 times more common in women than in men.
Wow, 6 times.
Yeah, it's a huge difference. And while there is a significant peak in diagnoses around or after menopause, up to 15% of cases are actually in children.
Wait, really? 15%?
Yeah, it's not just an aging issue.
And just to completely clear the air right at the start, because, the word lesion or plaque combined with genital origins just sends people into an absolute panic.
Right. Totally understandable.
This is purely a friendly fire situation from the immune system, right? It's associated with vitiligo or thyroid disease.
Absolutely. I cannot stress this enough. It is not an infection.
Okay, good.
It is not a virus. It's not a bacteria or a fungus. It is completely non-contagious.
So you can't catch it from a towel or something?
No, you cannot spread it. And it has nothing to do with hygiene. It is simply your own immune system becoming confused and mounting an inflammatory attack against your own healthy tissue.
Wait, but if this is purely an autoimmune response where the body attacks itself, why doesn't it just attack the whole body?
That is a great question.
Because if my immune system is circulating through my entire bloodstream, why is the extragenital version only showing up in these isolated random patches on the skin?
That is the core mystery here, and it brings us to a really fascinating concept, extragenital LS, which, by the way, accounts for a much smaller fraction of cases.
Right. The genital presentations outnumber these by more than 5 to 1, I think.
Exactly. More than 5 to 1. But it doesn't just appear randomly. It targets specific classical sites.
Like where?
We see it on the upper trunk, the axillate. So we're talking about the underarms here, the buttocks, the back, the shoulders, and the lateral outer thighs.
But those spots don't seem connected at all, the underarms and the outer thighs.
I know. It sounds totally random.
It sounds like a dartboard approach by the immune system.
Right. But what's fascinating here is a mechanism known as the Koebner response.
The Koebner response?
Yes. It looks random until you view it through the lens of mechanical physics.
Physicists. Okay, I'm intrigued.
The Koebner response occurs when an underlying skin condition is triggered or exacerbated by physical trauma or friction to the skin.
Wait, so the skin holds a grudge?
Basically, yes.
So it's like a motion sensor light that's wired incorrectly.
Oh, I like that analogy.
Yeah, the friction is the motion, and instead of just shedding a few dead skin cells like normal skin would, the immune system floods the yard with inflammatory spotlights and starts attacking the area.
That is a brilliant way to conceptualize it. When your skin experiences friction, even mild friction, the keratinocytes, the primary cells in your epidermis, experience microtrauma.
Okay.
In a healthy system, they release tiny chemical signals to initiate microscopic repairs. But in someone predisposed to lichen sclerosus, those chemical distress signals, which are called cytokines, they essentially trick an already hypervigilant immune system. T cells swarm the area of the friction, misidentify the tissue's basement membrane as a threat, and begin an inflammatory assault.
Which explains the geography perfectly.
Right.
If you think about everyday life, those dartboard spots are actually the primary sites of physical pressure.
Exactly.
Like the waistline where tight pants or belts rub against the trunk, the shoulders and under the breasts where bra straps dig in.
Yes, the underarms dealing with clothing seams and constant movement.
It's appearing right at the sites of mechanical stress.
Exactly. Even an old healed surgical scar or a site of previous radiation therapy can cobnerize.
Wow.
Yeah, the scar tissue alters the tension of the skin, and years later, it can become ground zero for an extragenital LS patch because the immune system is constantly patrolling those areas of altered mechanical stress.
So if friction is triggering this localized immune war on the shoulder or the waistband, what does the collateral damage look like to the naked eye?
Well, it's very distinct.
Because the medical guidelines describe this using vocabulary that sounds like a masterclass in obscure geometry.
They really do.
They use terms like porcelain white plaques, polygonal macules, and follicular dells.
Let's translate that collateral damage into a physical picture. The autoimmune attack primarily destroys melanocytes, those are the pigment-producing cells,
Gotcha.
and alters the collagen in the deeper layers. So it starts as what we call macules.
And a macule is just a spot.
Yeah, a macule is just a flat, distinct, discolored area. Because of the loss of pigment and the changes to the collagen, these are often an ivory or stark porcelain white color. They have a shiny quality to them.
And the word polygonal.
It just means they aren't perfect little circles. They have irregular, angled geometric borders.
Okay, that makes sense. And what about the follicular dells? That sounds incredibly specific, like a tiny valley.
Pretty much. A dell is a tiny indentation. Follicular dells means that if you look closely at the hair follicles within that white patch, the follicle looks pitted or sunken in.
Oh, wow. Why does that happen?
This happens because the inflammation causes a hyperkeratosis, a buildup of keratin right at the opening of the hair follicle, which paradoxically dilates it and makes it look like a tiny crater.
That is so strange.
And you might also develop areas of ecchymosis, meaning you'll see tiny bruised blood blisters trapped in that white patch.
Because the skin is damaged.
Yeah, the inflammation has made the local capillaries incredibly fragile.
So the immune system breaks down the pigment, pits the hair follicles, and weakens the blood vessels, leaving these shiny geometric white spots. But they don't stay isolated, do they?
No, over time, if the friction continues and the inflammation persists, these small macules merge together.
They become a bigger patch.
Exactly. They coalesce into larger areas called plaques. And as the collagen and elastin in the dermis are continually degraded by the immune response, the surface of the skin develops a very distinct, almost pathognomonic characteristic.
It is.
The skin becomes severely thinned and crinkled. Across almost all the dermatological literature, it is described as looking exactly like white, wrinkled tissue paper.
White, wrinkled tissue paper.
Yeah.
It's such a vivid, undeniable visual. And here's where it gets really interesting. If genital LS is notorious for causing agonizing, sleep-depriving itch and severe pain as the tissue breaks down,
Right.
what does it feel like when that exact same mechanism creates wrinkled tissue paper skin on your back?
It feels like absolutely nothing.
Nothing. Zero itch.
Almost universally nothing.
Are you serious?
Yes. It is a massive clinical contradiction that completely baffles a lot of medical students. The sources are unanimous on this.
Wow.
While genital LS is characterized by severe, distressing, destructive symptoms, extragenital LS is generally completely asymptomatic.
It rarely causes any itching whatsoever.
Very rarely. It rarely causes any pain or discomfort. Many patients live with it for years and don't even know they have it until a dermatologist happens to notice the white patches during a routine skin check for moles.
This just blows my mind. The cellular destruction is exactly the same. The white, crinkly appearance is the same. But the sensory experience is completely turned off just because it's on a shoulder blade instead of a mucous membrane.
Yep.
How is that even physically possible?
It forces us to realize that skin is not just one uniform wrapper around our bodies.
Right.
It is an incredibly specialized organ that changes drastically depending on its region. The genital region has an incredibly high density of nerve endings, a completely different moisture profile, a unique local microbiome.
And no outer layer, right?
Exactly. The tissue is heavily mucosal, meaning it lacks the tough, protective outer layer of keratin found on your back or shoulders.
Okay, so it's like a fire alarm going off in an empty warehouse on your back. It just doesn't register the same way as a fire alarm going off in a highly sensitive, densely wired control room.
Precisely. The local immune environment and nerve density of the extragenital skin completely alter how the disease's inflammation is translated into sensory signals sent to the brain.
And that environmental difference leads to another massive divergence, right? When it comes to the long-term risks associated with this tissue damage.
Yes, specifically regarding cancer.
Right, because that's always the scariest part of the diagnosis.
And this is arguably the most crucial distinction for a patient's peace of mind. In chronic, typical genital lichen sclerosus, the chronic inflammation and cellular turnover carry a small but well-recognized increased risk of developing a type of skin cancer called squamous cell carcinoma.
Okay.
It's why genital cases require lifelong monitoring. However, extragenital lichen sclerosus is not associated with squamous cell carcinoma.
Let me just pause and highlight that for you, the listener, because it is huge. If I have a patch on my shoulder, my cancer risk from that patch does not go up at all.
Correct. The sources are explicit. There is no increased cancer risk for the patches on your back, your chest, or your arms.
That is a relief.
Huge relief. The cellular environment of extragenital skin lacking that chronic moisture, friction, and mucosal vulnerability simply does not allow the inflammatory damage to progress into malignancy the way it can in the genital region.
That is vital. Imagine you're a patient reading your biopsy results. You go online, you see the word cancer attached to lichen sclerosus, and you go into an absolute tailspin.
It happens all the time.
Completely unaware that the risk doesn't apply to the specific version on your shoulder.
Yeah,
It really underscores why having accurate, updated terminology is so important.
it really does.
Which is funny because our sources note the medical community has basically had to overhaul the dictionary for this condition.
Oh, they've had to do quite a bit of housekeeping. Medicine constantly evolves, and old nomenclature often reflects outdated assumptions.
Like what?
For instance, in the past, when men developed this on the genitals, it was often called balanitis serotica obliterans.
Wow, that's a mouthful.
Right. And in women, it was sometimes labeled corrosis vulvae.
Wait, so what do we do with those terms now?
The British Association of Dermatologists guidelines explicitly say we should throw those terms out. They are synonymous with LS, and using them just muddies the waters and prevents unified research.
Makes sense. I also noticed a suffix that used to be attached to the main diagnosis. People used to call it lichen sclerosus et atrophicus.
Yes.
Why did they drop the second half?
Well, atrophicus refers to atrophy, which is the thinning or wasting away of tissue.
Like the tissue paper we talked about.
Exactly. For decades, dermatologists observed the wrinkled tissue paper appearance and assumed the disease purely caused the skin to thin out.
But that's not the whole story.
No. As biopsies and histological studies advanced, they realized the opposite can also be true.
The skin can actually get thicker.
Yes. In some cases, the skin epithelium becomes hypertrophic, it thickens, becomes raised, and highly hyperkeratotic.
Oh, wow.
So, labeling the entire disease as atrophicus was factually incorrect for a significant portion of patients. To ensure the diagnosis was universally accurate, they dropped the suffix entirely.
Speaking of confusing terms, you see the word leukoplakia thrown around constantly in online forums for skin and dental conditions. Patients will say, "Oh, my doctor diagnosed me with leukoplakia," as if they've solved the puzzle.
And it's a very common misunderstanding because leukoplakia sounds highly clinical, but it is not a diagnosis.
Really? What is it then?
The word literally translates from Greek as white plaque. It is a purely descriptive observational term.
Oh, I see.
Saying someone has leukoplakia is like a doctor writing down that a patient has a red bump. It describes the visual symptom, but it tells you absolutely nothing about the underlying cellular mechanism causing the white plaque.
So it's just a symptom.
Right. Lichen sclerosus can cause a leukoplakia, but so can a dozen other entirely unrelated conditions.
Okay, so let's tie all these threads together. If you have these white, shiny, crinkled patches on your back, and they don't itch, they don't hurt, and they carry zero increased risk of cancer,
Yeah.
why do doctors even care? Why are we even talking about getting it formally diagnosed if it's the definition of harmless?
That brings us to the crucial detective work of diagnosis. You must get it evaluated by a specialist, usually dermatologist,
But why, if it's harmless?
because they need to confirm that what you are looking at is actually extragenital lichen sclerosus and not its clinical doppelganger.
There's an imposter condition.
There is. It is a condition called morphea, which is a localized form of scleroderma.
Scleroderma, that sounds serious.
It can be. Morphea also causes thickened, discolored, sometimes white or ivory patches of skin, typically on the trunk or limbs.
So they look identical.
Visually, especially in the early inflammatory stages, morphea and extragenital LS can look incredibly similar to the untrained eye.
Wow.
But morphea involves a much deeper overproduction of collagen, and it can sometimes have different systemic implications. A specialist needs to rule morphea out.
So how are they making that distinction? Are they taking scalpels and doing punch biopsies on every white spot they see on a patient's back?
Thankfully, no. A specialist who looks at these conditions every day can usually make the diagnosis simply through visual inspection and pattern recognition.
Just by looking at it.
Yeah. The specific porcelain color, the crinkled tissue paper texture of the epidermis, the follicular dells we discussed.
The little valleys.
Right. And crucially, the geographic location at sites of pressure and friction. Those are incredibly strong diagnostic clues.
But what if it's a borderline case? Like, what if they aren't sure?
If there is diagnostic doubt, or if there's an atypical feature like an open sore that refuses to heal, then yes, they will perform a skin biopsy.
Okay.
They numb the area with local anesthetic, remove a tiny core of tissue, and examine the cellular architecture, the destroyed melanocytes, and the inflammatory T cells under a microscope to get definitive proof.
All right, so the dermatologist looks at the biopsy, walks back into the room, and says, good news, it's just extragenital lichen sclerosus. Best case scenario. What is the standard prescription for a harmless, painless patch of white skin?
If we connect this to the bigger picture of medical intervention often, the prescription is absolutely nothing.
Just go home and live your life.
Exactly. The medical guidelines from our sources clearly state that asymptomatic extragenital LS frequently requires zero treatment.
That is so wild to hear from a doctor.
In medicine, we weigh the burden of the disease against the burden of the treatment. For genital LS, we treat aggressively with ultra-potent steroids because the symptoms destroy a patient's quality of life and carry a cancer risk.
Right, that makes total sense.
But with extragenital LS, without the pain, the itch, or the malignancy risk, the medical necessity to intervene simply vanishes. We observe, we reassure the patient, and we leave it alone.
But let's look at this from the patient's perspective for a second. What if the patient is deeply uncomfortable with how the plaques look?
That's a very fair point.
Like, if you have large, coalesced white patches covering your shoulders or your chest, cosmetic concerns are incredibly valid. Or what if they are one of the rare edge cases where it does itch slightly? Do they have any options, or are they just stuck with the immune system's interior decorating?
No, they absolutely have options. If treatment is desired, dermatologists can deploy secondary strategies.
Like what?
The first line is usually the same potent topical corticosteroids used for the genital presentation.
So a steroid cream.
Basically, yeah. Applying these steroid ointments directly to the plaques suppresses the local hyperactive T cells and shuts down the inflammatory cascade,
Okay.
which can halt the progression and sometimes allow the skin to regain some normal texture.
I also noticed a really intriguing intervention mentioned in the BAD guidelines specifically for the extragenital version involving light therapy.
Oh, yes. Phototherapy.
How does shining a light on your back fix an autoimmune disease?
It is a specialized treatment, specifically narrowband UVB, PUVA, and UVA1. It sounds deceptively simple, but it's a profound manipulation of cell biology.
How does it work?
When specific wavelengths of ultraviolet light penetrate the epidermis and dermis, they interact directly with the DNA of those hyperactive immune cells.
Wait, so the light is actually altering the immune cells?
Yes. The UV radiation essentially induces apoptosis, which is programmed cell death specifically in the inflammatory T cells that are causing the damage.
Whoa.
It provides a profound, localized immunosuppression right where the light hits, without having to give the patient a systemic immune-suppressing drug that circulates through their entire body.
Because it would have way more side effects.
Exactly. It's usually reserved for extensive cases, but it demonstrates that we have powerful tools in the arsenal if these silent patches ever become a problem.
That is absolutely fascinating, using specific wavelengths of light to basically snipe hyperactive immune cells.
It's incredible technology.
And honestly, it is so empowering to pull back the curtain on the mechanics of a condition like this.
Oh, completely.
If you don't understand the geography of your own body, you are at the mercy of the worst-case scenario. You type the diagnosis into a search bar and immediately drown in anxiety about chronic pain and structural scoring.
And you just don't need to.
Right. But by understanding the nuances, by realizing that the extragenital version is playing a completely different game, you take your power back.
Knowledge fundamentally alters the patient experience.
Yeah.
When you understand the cellular mechanisms of your specific diagnosis, you stop carrying the emotional weight of symptoms and risks that literally do not apply to your biology.
Exactly. So for you, our listener, here's the final takeaway from today's stack of sources. Extragenital lichen sclerosus is a rare, localized, non-contagious presentation of an autoimmune-driven skin condition.
Yep.
Unlike its painful genital counterpart, this version is the silent sibling. Triggered by the Cogna response, the immune system overreacts to the simple friction of a bra strap or a tight waistband, destroying pigment and altering collagen to leave behind flat patches that look like shiny, wrinkled tissue paper.
Perfectly summarized.
But because of the unique environment of extragenital skin, it completely avoids the severe pain and the cancer risks, meaning that most of the time, the best treatment is just knowing it's there and leaving it alone.
This raises an important question, though, doesn't it? A biological mystery to chew on long after this deep dive ends.
Oh, I like a mystery. What is it?
We've just mapped out how the exact same autoimmune condition, driven by the exact same immune system within the exact same patient's bloodstream,
Right.
produces a destructive, risky disease in one area and a completely silent, harmless patch of white skin in another.
Yeah, that is weird.
It forces us to ask, what else is our localized tissue regulating that we haven't discovered yet? How many other systemic diseases are secretly being controlled or worsened simply by the zip code of the cells they attack?
Wow.
It highlights the staggering localized complexity of the human immune system and how the environment outside the cell is just as important as the DNA inside it.
A localized immune system, dictated by a cellular zip code. The environment matters just as much as the trigger. That is a perfect thought to leave you with today. Thank you to our expert for helping us navigate the microscopic mechanics of the skin.
It was a pleasure. Thanks for having me.
And thank you, the learner, for joining us on this deep dive. Remember, understanding the WHY is always better than just memorizing the what. Keep asking great questions, keep exploring, and we'll catch you next time.